So I think you saw this before, but I think the issue here is that fluid resuscitation is contentious. Obviously, we all want the beneficial effects of restoring fluid deficits and improving physiology, but we're well aware of many adverse effects, including the increase in mortality that was shown in the FEAST trial, and the adverse associations with positive fluid balance, and indeed the failure to achieve some of those beneficial effects. The traditional way people have thought about some of the adverse effects might have been summarised here by James Forrester in a pivotal paper that was in New England a long time ago, where he talked about the wedge pressure and what you saw in a chest X-ray. So at a wedge of 18 to 20, you might see distended upper lobe veins, and then an interstitial infiltrator, 25 to 30, alveolar infiltrates, and then flash pulmonary edema. And that just doesn't have any resonance with us, I think, anymore. Certainly we know that if you have a negative fluid balance, you often see an improvement in pulmonary edema despite having non-hydrostatic pressures. So I paused there for a second because I presented that in a slightly different forum to an academic cardiology group, and they were horrified that they're still working on that paradigm, and many of our colleagues are, I think. So I think, in addition to that, we really need to rethink this all, because we do need to consider why there might have been an increase in mortality in the FEAST study, and certainly there's been a suggestion that might have been due to circulatory collapse. So is there any way that we can tie that together? And I'm not really able to give you fact on all of this, but just a few signposts on the road, and then maybe and some dotted points as we go through there. So this is some data for some healthy volunteers where they were given isotonic saline, 30 mils per kilo of isotonic saline, and had lung ultrasound, echocardiography, and pulmonary function tests. And interesting, what it shows is that they developed interstitial edema, as suggested by the B lines on their lung ultrasound. And they had some abnormalities in their pulmonary function tests, but there were no changes in cardiac output. There were no changes in diastolic effects on the heart, and there was a non-significant change in NT-proBNP. Now, we have to be a little careful with that, because it takes about 4 hours for NT-proBNP to be synthesised and released. But nevertheless, there was, in summary, it would appear that in the face of normal cardiac function, you got interstitial edema with isotonic saline. If you do that same experiment in ventilated rats, a larger volume this time, and measure the LVDP, so you put a carotid artery cannula in and push it across the aortic valve into the left ventricle, you can see here that you do get, with fluid loading, you do get an increase in LVDP, but up below what James Forrester would have told us was a important hydrostatic pressure. And with that, what you see is an increase in lung water, but more importantly, an increase in the lung Labarge protein, telling us that there's been an increase in permeability. So there's been lung injury as a result of that. And with that, you see an impairment in oxygenation. If you look at under the microscope, what you see are more cells and thicker walls. So not only, this is not just fluid, this is lung injury. So fluid can cause lung injury despite having non-hydrostatic pressures. Now, to understand that, I think we need to go backwards a little bit and start thinking about a little bit of chemistry and a little bit of more basic biology. And I'm going to introduce you to the viable Pilates body, which is an endothelial storage vesicle, which has a whole lot of important chemicals in it, including P-selectin, angiopoietin-2, von Willebrand's factor, interleukin-8, and endothelium-1. About 15 years ago, Wolfgang Kubler and Jahad Bhattacharya published a great paper in Journal of Clinical Investigation in which they raised the capillary pressure modestly, I think it might have been 15 centimetres of water, and noticed that there was a sudden influx of calcium. Now, I think we would recognise that was probably activation of TRPV4, and certainly Kubler is suggesting that as well. So with that, they thought that there was an exocytosis and release of the viable Pilates content, including the P-select, and there was an increase in permeability. The neutrophils rolled, the neutrophils started to be adherent and infiltrated, and there was platelet adhesion. So something happened, some active process happened with that modest increase in pulmonary capillary pressure. It's interesting too that Carolyn Calfee looked at the ASM fluid trial and found some changes with angiopoietin 2. So I think you're pretty familiar with this trial, conservative versus liberal fluid therapy. But on a sub-analysis of that, the von Willebrand's factor data were not particularly, didn't show much difference between the different fluid groups, but the angiopoietin 2 levels were elevated, and in the conservative group had a greater fall. So something was happening. So that's consistent with this idea that modest elevations in pulmonary capillary pressure lead to release of angiopoietin 2, probably through TRPV4 activation. So most of you won't have heard of TRPV4, and I'm going to quickly talk about that and maybe how that helps us understand some of these things. Before I do that, and I don't really have time to talk about it much, but there have been massive changes in the paradigms of lung fluid balance over the last, 25 years, I think, since the initial observations of vectorial movement of sodium. And if you look on the, I guess it's the right-hand side of your screen, the right-hand side of your screen, you'll see there's supposed to be a type 2 cell there with the epithelial sodium channel at the apical surface with, at the basolateral surface, active exclusion of sodium from the cell. There's also the cystic fibrosis transport regulator channel here at the apical surface, and this sodium-potassium chloride channel at the basolateral surface. It's interesting, very similar channel arrangements exist in the kidney. Now, what's thought to happen when you elevate left atrial pressure, and therefore you elevate pulmonary capillary pressure, is that maybe through activation of TRPV4, and I'll talk about that in a second, there's release of nitric oxide. And with that, probably that nitric oxide ends up in the type 2 cell. Remember, they're just right on top of each other. Maybe the gaps are in the order of 0.1 to 0.2 microns. There's inhibition of ENaC, a reversal of polarity in the type 2 cell, and active extrusion of chloride. And the suggestion is that only 30% of alveolar fluid efflux is hydrostatic, so 70% of it's active. And that's clearly a major change in the paradigm of the way that we think about fluid. These TRPV channels were probably, you can trace it back to Landsman in 1987, where they were first described in aortic endothelial cells with this rapid calcium permeable channel, and this idea of vascular mechanotransduction. So mechanotransduction is where you have a force and a distortion or some physical change that leads to protein changes within the cell and changes within signalling. There's multiple TRP channels being described, but for this purpose we're just interested in the TRPV4 channel over here, and that's widely expressed in the heart and the lung. So TRPV4 seems to be stimulated by, or activated by, pressure and shear forces through activation of phospholipase A2 and arachidonic acid metabolites. So that's down the bottom here of this endothelial cell. With that, there's rapid calcium influx and probably activation of myosin light chain kinase, vasorelaxation, increase in permeability, increase in fluid flux and pulmonary edema. At the same time, this calcium is thought to activate eNOS with production of nitric oxide, and I briefly mentioned that, leading to the epithelium with inhibition of ENaC. And interestingly enough, drugs like sildenafil, which will can change this through cyclic GMP signaling and have been shown to decrease pulmonary edema. But it's this issue here that low pressures leading to rapid calcium influx can lead to these important changes. So with that in mind, we hypothesised that in the lung injury data that I showed you before in the animals, that this was TRPV4 activation, and so we gave the animals a relatively specific TRPV4 antagonist called Ruthenium red, and then gave them fluid. With that, and it's a bit hard to see on this table, but the increase in lung water, the wet-dry weight ratio, didn't increase. There was no increase in permeability, there was no increase in protein. There were no changes in mechanics, or they were all ameliorated. Lung oxygenation didn't get worse, and in fact, under the microscope, everything looked much as it had in the control group. So by antagonising TRPV4, we could antagonise or prevent this change in lung injury. Now, this is only a relatively specific TRPV4 antagonist, and some of this needs to be done with the more specific antagonists, but this is totally consistent with a lot of data that's been done with this drug, Ruthenium Red, other drugs, and the specific antagonists that are now available, and I think we'll see changing the way that we treat heart failure in the next 5 years. Oops. So that's interesting, but I think just as interesting is this interaction of angiopoietin-2 and the systemic circulation that potentially is on. And there's also a body of work suggesting that angiopoietin-2 is permissive to the action of cytokines in the periphery. And what I've got down here is a pretty complex diagram, so my apologies, but it's an endothelial cell showing angiopoietin-1, which is an antagonist of angiopoietin-2, being constitutively released from pericytes, in balance with angiopoietin-2, a tyrosine kinase receptor, looking after the health of the endothelial cell. So when you've got more angiopoietin-1, when an excess of angiopoietin-1, you have blood vessel stabilisation. But when you have an excess of angiopoietin-2, then you get inhibition of some of these control factors and permissive action of some of the cytokines in the peripheral circulation. Indeed, there are a number of experiments that would show without angiopoietin-2, cytokines in peripheral circulation seem to be extremely mild, if having any effect. So I'd suggest that these are dotted lines or dashed lines. So there's lots of bits that need to be filled in. That may be a fluid bolus. Well, I think we've got leads to endothelial shear forces, leads to TRPV activation, viable body degranulation, release of lots of things, including angiopoietin-2. The angiopoietin-2 sensitises to cytokines, including tumour necrosis factor, and that exacerbates some of the systemic effects, including neutrophil adhesion, increased permeability, and cardiovascular collapse. So, in summary, I think hydrostatic pulmonary edema is a misnomer. There's lots of active processes involved, and we need to educate ourselves and then educate our colleagues, because that's going to change the way that we think about some of these things. And it's interesting, Ronaldo, that the effect of frusemide on the sodium-potassium chloride channel that I showed you before there suggests that maybe frusemide causing a negative balance would be far more effective in pulmonary edema than causing a negative balance through hemofiltration, for instance. So that we can go and start addressing clinical questions like that. I think fluid therapy can induce pulmonary edema and lung injury at what was previously considered safe hydrostatic pressures, and that probably involves TRPV4 activation, degranulation of viable bodies. The subsequent increase in angiopoietin-2 sensitises endothelium to cytokines, and that accelerates the inflammatory response. And I think that's exciting stuff to explore in the next decade. Thank you.
We've got time for a couple of questions if the audience wants to ask. So Andrew, now we have to worry about capillary stretch as well as alveolar stretch in the lung.
Yes. So there is, and of course it's very hard to differentiate those two. So if you have, because obviously alveolar stretch obviously applies some of these stretches to the capillary and vice versa, obviously. So, but certainly with the TRPV4 story is fairly well developed in ventilator-induced lung injury. There's quite a bit of data in that area, and whether it is actually at the capillary or whether it's the TRPV4 on some of the alveolar macrophages is a little less certain. But yes, yes.
No stretch.
It's stretch.
No
Go
stretch.
stretch. Go stretch.
No stretch. Manoj, please.
Hi, Andrew and Shailesh. Brilliant work and really, really interesting. Have you looked at, so there's obviously stretch occurring with a fluid bolus. Another way that we give fluid clinically is maintenance fluid and fluid with replacement with electrolytes, and does that kind of more chronic or subacute stress that occurs with gentle volume overload, does that have the same effect? Do you know?
So, look, I don't know. What's thought to happen in chronic heart failure, which is sort of very chronic stretch, is that there is a down-regulation of the enos of the endothelium, so that it does all change depending on the chronicity of it. Now, I don't think that's relevant to us in the ICU, but cell signalling changes occur within 3 or 4 hours. So maybe it is. I don't think we know the answer to that.
Okay. Thank
Okay,
you.
great.